Thank you for listening to Depictions Media Radio.
Hello, good afternoon, good morning, or good evening to everyone from the World Health Organization headquarters in Geneva. My name is Alexandra Kuzmanovic, and today I'm very pleased to be joined by Dr. Mariangela Simao, our Assistant Director General for Medicines, Vaccines, and Pharmaceuticals. And we will be joined at some point by Dr. Bruce Aylward, who is the Senior Advisor to Director General and who is the Accelerator lead. As many of you have asked us in past weeks on how you can help us to deliver on vaccine equity following the call to action from our Director General, and also asking on countries to work together to vaccinate at least 10% of population in every country by end of September. So today, Dr. Mariangela and Dr. Bruce will answer your questions on this subject and tell you where we are at the moment, what are the efforts we are putting to really deliver vaccines to health workers and most vulnerable populations in every country. Good afternoon, Mariangela. Thank you for your time today. I know you and Bruce and Kate and others have very long days working on this subject, but maybe we can start before moving into distribution and challenges to remind our viewers what are the currently available vaccines that are approved by WHO and used around the world.
That's a very good question, and because this is moving all the time, right? But first, before I say, because you're talking about vaccines being available, I mean, these vaccines that I'm going to mention, they are being manufactured doesn't mean they're being available everywhere, right? Because I think the issue of the vaccine inequity in the world right now is so important. We'll be discussing this a little bit more. But we have, that we have different platforms for vaccines, right? We do have, people know, we do have two vaccines that are using the technology of the messenger RNA, right? And these are the Pfizer and Moderna vaccines. We have two vaccines that use what we call an adenoviral vector. We have the Janssen vaccine, which is also the J&J, the same vaccine. And we have several AstraZeneca producers. We have a core producer from AstraZeneca, and then there are maybe 8 or 10 manufacturers around the world that produces AstraZeneca. And we do have the inactivated viral vaccines that are right now have been approved by WHO in the first semester, which is the Sinopharm and Sinovac, two Chinese vaccine producers. So these different platforms, they work differently in the body. Right. We have, everybody knows that we produce these vaccines very quickly, and there are other vaccines coming up. WHO does what we call the emergency use listing of vaccines, because that facilitates, we assess the data, the information that comes from the manufacturers, and depending on the manufacturer, we also do a physical inspection in the manufacturing facility. And then we do this emergency use listing. Some countries call it an emergency use authorization, and this is very important because it means that not every country needs to do it. They can rely on WHO to certify that vaccine or to register, allow the market entry at country level. I'm saying this because we have 6 other candidates that are being assessed or are beginning the assessment right now. So we have a candidate that started, Bharat from India, that started in July. We have 3 starting now in August, and 2 starting in September. So the more vaccine producers we have, the more variety we have of vaccines that are safe and effective, efficacious. The more we have, the better we are globally, because there's more supply.
Thank you so much, Mariangela. I just want to remind viewers as well, if you want to ask a question on Twitter, please use the hashtag AskWHO. If you're watching us on Facebook or LinkedIn or YouTube, please leave your questions via comments section as usual. But just a reminder for someone who is new joining us today, we're talking about vaccine equity. Mariangela, what are the impediments to distributing vaccines equitably, as since vaccines, first vaccine has been approved and start being using, I think, in December last year. We've been calling for equitable distribution and protecting health workers and most at-risk people, but that's not what we are seeing everywhere.
We have a situation where we have more than 4 billion vaccines have been administered globally, right? But it's a very unequal distribution, right? When we are talking about equity, it's such an important topic right now, because we cannot say that there is that we're not producing lots of vaccines, because we already deliver 4 billion, right? So this is what we have is a market play in this. You know, the market is behaving like it always does, not as if we were in a situation, on a pandemic situation, you know, where every country needs to achieve a certain coverage to cover at least those people who are at high risk of getting severely sick or dying, in the health workers, because they're the backbone. Without health workers, you don't have, people get sick, they don't have where to go. So the situation we have right now is that there is, first of all, there is a diversity of producers, but some producers are prioritizing high-income markets. Now, and this is something that we are seeing, and we do have a global mechanism. We call it the Covax facility, which is like a consortium of countries and that has agreements, contracts with manufacturers, but the Covax facility is having difficulties in getting the supply. So we have a situation where we have a great demand for vaccines, and the supply is concentrated on fewer producers. You have producers like, for example, AstraZeneca, who's producing at what we call a cost plus, which means it's a non-for-profit production, and it's diversifying the manufacturing around the world. And then you have producers that are producing in very few countries and concentrating their delivery in high-income markets. So we need to level this playing field, because it started already, because some of the high-income countries have started donating doses, which is super welcome at this stage, where you have constraints in the supply for lower and low middle-income countries. So we expect that by the end of this year, things will get better for all countries.
Thank you so much. And what are the solutions to this problem? We do have some solutions, and I know the Director General has been giving suggestions to countries, to manufacturers, but maybe as well you can explain to our viewers what are the solutions that could help us to resolve this earlier than end of the year.
Like, for example, there is a lot of interest right now in local production, right? And that's a mid to longer term solution. It won't sort out the problems of supply by the end of this year. But it's extremely important as we think about pandemic preparedness and country preparedness. You know, across all regions, we can't have the concentration we have right now, with some technologies being produced only in 1 or 2 countries. You know, so we need to, and WHO is working with partners to increase local production, the manufacturing capacity in countries, vaccine manufacturing capacity in countries. WHO launched an expression of interest for example, for the mRNA, the messenger RNA hubs, and we launched the first one in South Africa. So this is to increase the availability of technology in different regions of the world, not only between Europe and the US. Right? The other big push is for us to have, so you need to increase supply longer term, right? And WHO working with other partners on this as well. We also need to distribute the vaccines more equitably. And here on there's a confusion. People many times think that equal distribution equals to equitable distribution. It's not the same thing, right? Because at the stage we are right now, when you have many upper middle income countries and high income countries with coverages of 60, 70% or more than 50% of their population, at the same time you have a huge amount of countries with less than 10%. in some countries with less than 1% coverage. You know, so this is all the efforts WHO and partners are doing right now is to decrease the equity. That means that we need to increase the distribution to countries who are lagging behind in coverage. You know, and this is done through the Covax facility and also done through the donation of doses from some bilateral agreements. But this is super important at the moment.
Thank you so much, Mariangela. We're receiving already quite a lot of questions from our viewers. There are two around. One is asking, do we need a third dose of the vaccine? But then there is a question, actually, how this can impact the distribution. How can we strengthen Covax to receive more vaccines and distribute equitably? The booster dose in high-income countries can further widen the equity gaps.
With the booster dose, because we see it every day in the newspaper, there are interviews everywhere, but do we need a booster or not? At the moment, the science is not there. You know, so when you see some countries pushing for the booster or establishing policies that say that now you receive this vaccine, so you should have a third dose, there's no science behind. What do we mean when we say there's no science behind? There is no scientific evidence yet that we need to have a third dose or a second dose in the case of a J&J vaccine. You know, so that's one part of it. So the politics have been playing a lot during this pandemic, right? So people get nervous and so on. But the science is evolving, and the science for the third dose is not there yet. And there is also the issue that I was mentioning before, because if you start giving doses, third doses, that will happen in countries that have the high-income countries that can buy these doses, right? Because they're not cheap doses at this stage, right? If you do that, you're taking away the chance of health workers and vulnerable groups, which are the older people and people with comorbidities, people with associated diseases that are at higher risk of dying of COVID, of them not being able to receive the first dose because a third dose is being used somewhere else where it's not necessarily needed. You know, so this is I think it's an ethical dilemma at the moment. Right? WHO has been pushing, Dr. Tedros has been mentioning that there should be a moratorium on the third dose, on the boosters. And this is this is extremely important at the moment because we need to bring all these countries, the populations that are being left behind, up. And I'm saying this also because it's not only because there's not enough vaccines, but also not because there's no scientific evidence. It's also because it's everyone's interest, you know, that all countries are covered. You know, because everyone is seeing the havoc that the Delta variant is causing right now. You know, so whenever you have countries that have low coverage, you have the conditions, it's the contest for the variants to appear, you know, new variants to appear. So Dr. Tedros has been saying, and I repeat it all the time, because it's also in everyone's best interest. So it's a matter of self-interest too, you know, because as long as some country somewhere doesn't have enough coverage, the virus is breeding and it can mutate and create a new variant. So we need to bring everyone up.
Thank you so much. Here are more and more questions. Some are also coming about age groups and the recommendations that we have at the moment, whether we will recommend for adolescents and children to be vaccinated. And one question is actually in particular in the African context, as it's a younger population on the continent, would we advise for adolescents and younger age groups to be vaccinated?
Yeah, you know that WHO doesn't make this type of decision on its own, right? WHO has a group of experts which meets regularly and advise WHO based on the best scientific evidence possible. Why aren't the vaccines, when you started, why wasn't children, you know, or adolescents first target? Because when you have new products, you don't test in children. right? Which is an ethical thing. And you don't test in adolescents and you don't test in pregnant women. So with time, we got some evidence regarding safety in pregnant women, and several countries WHO started recommending in certain contexts, and now we have some studies showing the safety in adolescents, but the WHO is still, the expert group is working on this, but we don't have yet the information, the necessary scientific information about safety in children. But we do know that children it's very rare to develop severe disease, right? So again, we go back to the priority, right? First we have, because then in children, it's the two things, right? The safety and the fact that you need to take into account whether, the children have a high-risk situation or not, right? Because they don't develop severe disease. And this feeds into the issue of an inequitable access, right? And that whatever vaccines that you divert and you move towards non-prioritized populations, you're leaving some health workers and hypertensive people with renal disease, diabetic out.
Thank you very much. And we're getting more questions on how we decide to distribute vaccines among populations. And I think that Bruce is arriving just in time as we are receiving more questions about Covax and distribution of vaccines. But while he gets seated here, Mariangela, maybe I can pass this question to you from our Twitter viewer. Is the prevalence of SARS-CoV-2 in the population of a country a factor in deciding which countries to prioritize in getting vaccines?
No, that's an excellent question, actually, because there are many people in many countries who are going through a crisis and have an outbreak, a surge in the number of cases, who keep pushing for vaccines. And we know that vaccines, the vaccine coverage has to increase over time, because vaccines on themselves, they are not a good acute response. So this is super important. What WHO does with Gavi, we run what we call an allocation mechanism, where we get a number of doses. We're working on this right now. Let's say for October you have X million of doses, how we are going to distribute across the countries, right? So then we take into account now the coverage, and we're working on something that can reflect the epidemic trend, the mortality and the number of cases. So it's a very important question, but again, during an acute phase, when you have the virus, the community transmission running wild, lots of cases, you need to put in place the public health measures. It's not the vaccines help, but they are an additional tool over time. You need to make sure people wear masks, that people wash their hands or use alcohol if available, that you avoid crowded places, ventilated spaces. All these public health measures, they have not gone out of the window just because we have the promise of a vaccine. They need to be, and they are the measures that will help in a crisis situation. Plus, of course, quality of care.
Thank you so much, Mariangela, and welcome to Bruce. Thank you for your time. We know we took you away from an important meeting on ensuring more vaccines to be distributed. As Mariangela mentioned, we don't have only vaccines, but we have other tools. And as you're leading the ACT Accelerator, maybe you can tell us more, what is the ACT-A doing and how it's functioning to really ensure equitable distribution of all different tools to fight COVID-19.
Sure. Thank you, Alex, and good afternoon to everyone. So the ACT Accelerator is this bold idea that the Director General of WHO and some other health leaders came up with last year, that they were looking at where we were in the COVID response, and this was early first couple of months, and they realized we simply have not got the tools that we need. We're going to need a more rapid, we had two big objectives: to more rapidly develop these tools and make sure they're equitably distributed, meaning fairly distributed around the world. And the Director General and this group of other health leaders, the solution they came to is, let's take all these great global health agencies and repurpose them in the short term to try and make a big push to get vaccines, diagnostics, therapeutics, and PPE out to the world. And so now we have 10 agencies collaborating, working together. So ACT Accelerator is just a name for 10 agencies that work together on a day-to-day basis, like Mariangela has been describing, to try and get these tools out. So they've really had, they work right across what we call the value chain for tools, all the way from research and development to make sure the right research is being done, to make sure that these tools are properly assessed, evaluated, et cetera, right down to being distributed out to countries that need them. And when we talk about equity and trying to ensure everyone who needs them have access to these tools, you have to think right across that value chain, all the way from research and development to in-country delivery. And every single piece of that chain has got to be optimized, let's say, for that purpose. So the ACT-A partners, they engage in the research, make sure it's the right research. Take vaccines, for example. Like, single dose is more easy to use than 2 doses. A vaccine that doesn't need an ultra-cold chain is going to be more useful than one that needs an ultra-cold chain, et cetera. So right up in the R&D side, you're looking at those issues, and then helping countries evaluate them, distribute them, and then even be able to use them in the field. The single biggest challenge we're finding now, Alex, though, is not the tools themselves. That's turning out to be the easy part. The hard part is making sure everybody who needs them gets them. If we look at the situation today, right, 30% of the world has gotten at least 1 dose of vaccines. In Europe, North America, South America, 50% of the population has gotten at least 1 dose, and in most cases 2 doses. In Asia, Oceania, it's about 30%. In Africa, it's less than 5%. So the big push we're doing now is calling on the vaccine suppliers, calling on the countries that produce vaccines, the countries that are buying all the vaccines, to take a step back from the high-income countries and focus on the low-income. And we're trying every single mechanism possible to enhance that.
Thank you very much. And I have already a follow-up question from someone watching us on LinkedIn. What is Covax doing to break the bureaucracy of vaccine acquisition by low-income countries like African countries?
To break the
bureaucracy of vaccine acquisition by low-income countries, for example, African countries.
So the first thing we're trying to do is make it a heck of a lot easier for countries to access vaccines. So we set up Covax, which we tried to make kind of a one-stop shop, let's say, for countries and for donors. So what we've tried to do is put together within Covax the ability to assess and pre-qualify vaccines to make sure they're safe, efficacious, et cetera, so countries are buying the right vaccines. We've tried to pool as much of the demand as possible to get the best possible prices for countries. We've tried to match that with donors, with the World Bank, with other financing sources to make that available. We haven't tried on all of these things, we've done it actually. We've put in place what we call a no-fault compensation scheme to protect anybody or compensate anybody who should have any kind of an adverse reaction that causes death or severe disability. It's super rare, but we've put in place a mechanism for every country. So there's been a whole lot of work done with the countries of Africa to put together a mechanism that makes it a lot easier to get safe, affordable, efficacious, and appropriate vaccines, as well as diagnostics, and in the case of oxygen, dexamethasone, in the area of therapeutics.
We also use for the procurement of vaccines, we use the big procurers. One is UNICEF, who buys already vaccines for the world, and the other is the PAHO, revolving fund. So this also helps, because countries then they make the orders, or they get allocated those, and those are shipped using these big mechanisms that already have the know-how, and so that you don't have to go country by country doing bilateral agreements to get the vaccines into the country. So
yeah, and sorry, Alex, to come back because it's such an important issue. And Covax works from end to end. It works. The problem is you can't distribute vaccines you don't have. And if countries are going to hold on to vaccines, if manufacturers are going to send them to people that already have a lot of vaccines, if countries that already have a lot of vaccines are going to pay more money and demand that they're at the top of the queue, Covax can't achieve its mission. But it's already proven it can work. 200 million doses out to over 138 countries. And remember, Covax is getting to the tough places in the world. It's easy. Now, as hard as it is, people in Europe and in the U.S. and in Canada and elsewhere who are listening, you know how difficult it was in your countries to get vaccines out to everyone. Those are the easy places. Covax is working in the war zones. It's working in the impoverished countries, the no infrastructure countries. The system works, but we need your help to get vaccines to the people who need them and the machine that's set up to get them there.
Thank you very much, Bruce. And here is a question from someone watching us on LinkedIn, which is follow-up to what you just said. How is WHO supporting countries, especially in Africa, to be ready to actually administer all these vaccines that are coming and will come?
So remember, the first vaccine that was used anywhere in the world in terms of a licensed vaccine program was in December, and that was in a high-income country in the UK in early December. In October of last year, we were working in every low-income country, every developing country, to help them develop what we call the national vaccine deployment plans. Those plans had 9 different aspects to them, everything from the communications to the financing to the cold chain requirements, et cetera. So we began that planning process way back then with the countries. And it wasn't just WHO. WHO, UNICEF, the World Bank, all joined together with NGOs, civil society partners, under the leadership of ministries to help them put together the national plans, then to get the financing in place to make those plans work, then to get the training in place. So the work has been going on since last October. And that's the reason that so many of the developing countries, they're using the vaccines as soon as they receive them. We're seeing, unfortunately, press coverage of countries that aren't using vaccines, and what we're not seeing is the 75% of low-income developing countries that are using every vaccine the second it lands in the country. They're getting them out and using them because they've been working so hard to prepare. But that's only part of it. You also have to make sure you got the regulatory processes in place and pathways. You got the customs processes in place. It's a complicated business. So it's not just WHO. We could never do it by ourselves. We need the governments, need UNICEF, need all the other players with us.
Thank you so much. And here is the next question from someone watching us on LinkedIn. Vaccine uptake for health workers has not been impressive. How can we accelerate the coverage of healthcare providers?
I think it depends a lot on the countries, because we've seen wherever it's available, really, in lower and middle income countries, we don't have a problem with coverage of healthcare professionals. So, but we do see vaccine hesitancy, but it's not only in high-income countries, but it's mostly a high-income country problem. And we see even brand hesitancy, if this vaccine or that vaccine, should I wait for that? No, this is a luxury, actually, that not many people in the world have, right? So we always say that if you're being offered a vaccine that has been emergency use listed by WHO or by one of the stringent regulatory authorities, it's been approved by your national regulator, or take it, wherever it comes from, because it's been quality assured and the safety has been established. So it's something. I think that now we do have some countries that's struggling, because as long as you don't have the coverage in the population, especially the healthcare workers, right? Let's say if you have access to a vaccine, you're a healthcare worker, and you're not taking it, there's something very wrong, with your information or with the system you're working with. Right? That's
Thank you.
But and on that point, Alex, I think we have to remember the healthcare workers, at the end of the day, they're human. right? I mean, they've been superhuman in the course of COVID with what they've been doing, but they're going to suffer the same challenges other people do. There's a flood of information out there, of misinformation. They have questions, just like other people have questions. Lots of healthcare workers do. So we have to approach the same way. Accurate information. We've got to be able to listen to concerns. A lot of dealing with hesitancy is about listening to the concerns, and then trying to address those systematically, and also making it easy. It's got to be easy to get vaccinated. Remember, you're asking healthy people to interrupt whatever they're doing and get vaccinated. It's got to be affordable. It's got to be easy. It's got to be available. All those same challenges that we face. But like Mariangela said, healthcare workers, we need them to lead on this, just like they've led on every other part of this outbreak.
Thank you very much. Here is the next question, I think again from the LinkedIn viewer today. Is WHO planning to deploy its own personnel on the ground in Africa in particular to make sure that vaccines are reaching everybody in need?
Okay, we deployed our people in Africa and everywhere about 47, 48 years ago, I think, when the organization was established. We've been there ever since. So, the World Health Organization has a physical presence in over 150 countries. And a lot of the presence that we have out there are actually immunization experts. They've been part of the polio eradication programs, the measles or elimination programs, other big vaccination drives. And of all the different public health interventions, I think our teams and UNICEF teams probably know immunization as well, if not better than anything else. So we have a huge, thousands of people on the ground, and we're hiring additional folk. Often the people you need, though, Alec, are not international experts to come in, because you need people who understand the culture, understand the country, and they can bridge the science and the questions with the local concerns. You have to understand the context. So important in everything we do.
Thank you very much. We're getting some questions around the role of the producers, private sector in ensuring equitable distribution. So maybe you can remind, Mariangela touched upon that, but maybe we can remind again, what are those activities or actions that they can take in terms of sharing know-how, licensing, etc., to help us with vaccine equity?
Yeah, no, this is super important as well, right? Because I was mentioning in the beginning, Bruce, I was talking about the marketplace, and how we need the market to play differently from normal times, right? We already don't like it when it's only profit-based, right? Because we think that medicines, vaccines, and products that save people's life, they should be quality assured, but they should also be affordable, right? Because sometimes it's so expensive that people cannot pay out of pocket. 100 million people go into poverty every year because of out-of-pocket expenses with health. So we need to have a balanced approach at the moment. And Dr. Trader has been saying WHO is not against profit, but we need right now to have everyone's understanding, manufacturers, and we're also talking to the, how do you call the people who invest in investors, yeah, and to have the understanding of the public health need right now, because as I was saying before, this is in everyone's self-interest. It's not on this interest of this nation, that nation. WHO doesn't have a say on it, except to say that if we don't find a global solution, we won't get out of this pandemic so easily. So we need to have the sharing of technology, which is not happening in the scale that we need. We do have, like I was saying, the AstraZeneca working with different manufacturers across the world. There's a discussion at the World Trade Organization on a TRIPS Council about the waiving of the intellectual property rights, which is a very controversial discussion happening at the TRIPS Council. It's not a WHO discussion, but WHO has been pushing for whatever brings access closer to people, right? And there's also the issues about the voluntary licensing of intellectual property rights. This is the right time to do that, because this is the time when we need everyone to come in. Manufacturers, the governments who invest in the manufacture, the shareholders who understand that this should not be a profit-only approach right now. you need to, of course, you need to have a sustainable return on your investment if you're an investor, but we need this to change the global landscape right now.
It's such an important question, and we've got to get serious about this problem of inequity. We're going to talk about vaccines, but it's the same problem with oxygen, same problem with PPE, same problem with diagnostics. But if we just think about vaccines for a second, we ask, well, what do we need these people to do? There's probably 20 people in the world that are crucial to this, solving this equity problem, right? They had the companies, the big companies that are in charge of this, they had the countries that are contracting most of the world's vaccines, and they had the countries that produce it. And we knew those 20 people to say, you know what, we're going to solve this problem by the end of September. We're going to make sure 10% of every country in Africa is vaccinated. Right now, that's 1%. That's, I mean, we should be, just collectively disgusted with ourselves. I can't help but think, if we had tried to withhold vaccine from parts of the world, could we have made it any worse than it is today? I mean, we need these 20 people to stand up to challenge their boards, challenge their chairmen, challenge their shareholders, challenge their populations to say, we've got to fix this problem. Mariangela said, it's in their self-interest. Yes, but who cares, right? If we really believe people are created equal of equal value, we have to behave differently. We have a narrow window right now before we get into the fall where we've got to get to 10% in every country. If we get that, we're going to get some degree. So let's call it the sprint to September, right? And then the dash to December. We need 20 people to lead the world's effort to change what is I hate to use such strong language, disgraceful situation we're in. And that's why these fora like this are so important, because it's going to require the average people telling, average people, nobody's average, but it's telling your politicians, your leaders, this isn't good enough.
I was just actually about to ask what each of us on individual level can do to support vaccine equity.
Well, use your voice. The most powerful thing is you have your voice, and you live in this incredible era of social media where you can amplify your voice. Use those tools, use those mechanisms. Call out not just your leaders, the leaders of the countries that are contracting most of the vaccine, the heads of the countries, of the companies that are making these vaccines, and help them. They know the situation even better, as well as we do. They want to do this, but they need their shareholders behind them. They need their populations behind them. And what we need is you to use your voice to say, we're behind you. Move the vaccine to these. It's electorally safe. It's investment safe. Do these things. Use your voice, and then bring your voices together. It's so powerful. That's what politicians listen to. That's what corporate leaders listen to.
Mariangela, what are your thoughts?
I couldn't agree more with the collective view and how because each of us, to say you're apolitical, it's actually you're taking sides, right, to the status quo. You need to be proactive in order to change society. But I would add to what Bruce was saying, in the individuals also on their ability to convince others to get vaccinated. That's the other thing, right? That you use your persuasion powers also because pockets of unvaccinated people in any country are not good. If you have vaccine available, please work with your neighbors, with your family for them to get vaccinated. If you can influence, and everyone can influence politically, like Bruce was saying, about on the equity side, getting vaccines to the places where they're not getting them, please do your best, because I think this is the moment when we need to do our best.
I think the other thing, Alex, people can do is, challenge the myths. People will say, oh, yes, but they can't use the vaccines, or they can't deliver the vaccines, or there's this problem or that problem. Challenge those things, because as soon as you use your voice and you start amplifying, you start challenging powerful people are going to push back, right? So you got to be prepared to lean in. And that information is available, right? Go onto the WHO sites, go onto the Covax sites, go onto the other sites. Whatever you need to be successful in your advocacy, our job is to help with the evidence to get behind it.
Yeah, I like to remind of a historic fact, right? Because I come from Brazil, right? A developing country, which in 1996 decided to treat AIDS patients. And it took 10 years between the discovery of the antiretroviral therapy for it to reach developing countries because, the international partners were saying, no, they can't handle it. So the same thing we are starting to see with vaccines now. No, countries won't be able to handle the vaccines. Countries know how to vaccinate, because this is the routine for children. We are still learning how to approach adults, but we can't afford. It's not only because of all the issues that I raised on the variants and everything else, but morally, ethically, the world can't afford to wait 10 years. Like 70 million people died of HIV before action was taken. But this is not possible right now. So we need to change the situation. We need to learn from the past, and we need to ensure that these vaccines reach countries and will help countries that have delivery problems. There will be. We work with one by one, and we'll sort it out.
Thank you very much. And here's one of the last questions from a LinkedIn viewer again. What is the actual situation on funding Accelerator? What the actual financial gap is, and what it will be expected by G20 countries?
So the financing gap right now is $16.8 billion. That sounds like a lot of money. There's 8 billion people in the world. There's half of those live in low-income countries. This is not much money. And you look at what we have spent in the high-income countries. So if you just take the G20 countries, they've spent, gosh, what's the number now? Over 10 trillion, $15 trillion just trying to deal with the consequences of the COVID-19 outbreak. So 16.8 billion sounds like it's a lot. It's less than 0.5% of what countries have spent trying to mitigate it. So it is a lot, but to Mariangela's point, it's in the self-interest of countries. Now, part of that is to deliver vaccines, but a lot of it is to be able to diagnose the disease. And people forget, in a lot of low-income countries, right, they don't have vaccines, but they also don't have tests. So people get a fever, you don't know if you have malaria, you don't know if you have TB, you don't know if you have HIV, you don't know if you have a pneumonia, you don't know if you have COVID, and it's very hard to protect yourself, protect your family. So we have to close all of those gaps. So a lot of our gap is for tests, it's for oxygen. Countries don't have oxygen. Terrible way to die, not being able to breathe, terrifying way. And they don't have just basic masks to be, we talk about our healthcare workers, we can't protect the healthcare workers in these countries. And sounds like a lot of money, but it is a fraction of what we're spending here. So that's the immediate need. Now, tomorrow, we're going to launch an appeal, and the world can watch the Delta virus surging around the world, and everybody's thinking, well, we need to get a vaccine, we need to do this. We need to get diagnostics, treatments, et cetera. So tomorrow, of that 16 point out, we're going to go out and urgently appeal for $7.7 billion to try and help those lowest income countries survive Delta while we get vaccines to them, and we try and solve the other problems we've been talking about here today.
Thank you so much.
Thank you for listening today, and thank you for supporting us with our sponsors. Please go to depictions.media for more information, and click on our contact link and let us know how we can help bring your story and help bring us to a better world. This show has been produced by Depictions Media. Please contact us at depictions.media for more information.